Welcome to the StudyNeuro neurosurgical teaching series. In this video, we'll explore the pathophysiology of degenerative cervical myelopathy and examine how chronic spinal cord compression leads to progressive neurological dysfunction. We'll discuss the roles of static and dynamic compression, the impact of cervical stenosis and spondylosis, and the mechanisms of ischemia, excitotoxicity, and apoptosis that contribute to spinal cord injury. We'll also review key radiological risk factors and how biomechanical changes influence disease progression. If you enjoy our content, please like, subscribe, and follow StudyNeuro for more neuroscience and neurosurgical education. Let's get started. Degenerative cervical myelopathy is the most common cause of spinal cord dysfunction in adults. It develops when the cervical spinal cord is exposed to ongoing compression over time. This matters. The disease process is complex. Structural changes in the spine can narrow the spinal canal, while normal neck movement adds repeated mechanical stress to the cord. Next to these effects, reduced blood flow and cellular injury contribute to progressive neural damage. As compression continues, neurological function may gradually decline, and some deficits can become permanent if treatment is delayed. Understanding these underlying mechanisms helps explain both symptom progression and the importance of early recognition. Degenerative cervical myelopathy develops through several overlapping processes that gradually damage the spinal cord. The condition often begins with narrowing of the spinal canal, which reduces the space available for the cord. This is a key factor. Over time, normal neck movement can expose the compressed cord to repeated mechanical stress. At the same time, blood supply may become less effective, creating chronic ischemia that limits oxygen delivery to spinal cord tissue. Next to these changes, injured nerve cells may undergo excitotoxic damage and programmed cell death, which further reduces neurological function. As the disease progresses, nerve fibers degenerate and the protective myelin covering is lost, leading to worsening signal transmission within the spinal cord. The result is a gradual decline in neurological function that can become irreversible. Static factors in degenerative cervical myelopathy are structural changes that reduce the space available for the spinal cord. These changes create persistent compression. That compression matters. In some individuals, the spinal canal is naturally narrow from birth or development. More commonly, age-related cervical spondylosis causes progressive narrowing as the spine undergoes degenerative change. Disc height may decrease over time, while bone spurs can form and project into the canal. The process does not stop there. Enlargement of the facet joints and thickening or even calcification of the ligamentum flavum can further reduce available space, creating chronic pressure on the spinal cord and increasing the risk of neurological injury. Cervical spinal canal stenosis refers to a reduction in the space available for the spinal cord. Measuring the canal diameter helps estimate the risk of cord compression. These numbers are important. A normal sagittal canal diameter is typically around 17 to 18 millimeters. As the canal becomes narrower, the likelihood of myelopathy increases, and when the diameter falls below 10 millimeters, absolute stenosis is generally present. Radiographic assessment often uses the Pavlov ratio, which compares canal size with vertebral body size. When this ratio falls below 0.82, the risk of myelopathy rises substantially. Because X-ray magnification can affect absolute measurements, ratio-based assessment is often preferred in clinical practice. Cervical spondylosis is the most common static cause of degenerative cervical myelopathy, accounting for more than half of cases. It develops through age-related changes in the cervical spine. This process is gradual. As intervertebral discs lose height, the spinal canal can become narrower and place greater pressure on the spinal cord. Disc herniation may further reduce available space, while repeated microinstability can stimulate the formation of osteophytes, or bone spurs. The effects often combine. Enlargement of the facet joints, together with disc and bone changes, can progressively increase stenosis, leading to chronic spinal cord compression and ongoing neurological injury over time. Several other structural abnormalities can also contribute to degenerative cervical myelopathy. One example is ossification of the posterior longitudinal ligament, where a normally flexible ligament gradually turns into bone. This can significantly narrow the canal. Changes in the ligamentum flavum may have a similar effect. When this ligament becomes thickened or calcified, it can encroach on the space surrounding the spinal cord. Next to these findings, facet cysts may develop and further reduce available room within the canal. The combined effect is important. As these structures occupy more space, the cross-sectional area of the spinal canal decreases, leading to greater mechanical compression and progressive stress on the spinal cord. Degenerative cervical myelopathy is not caused by static compression alone. The cervical spine moves constantly during daily activities, exposing the spinal cord to repeated mechanical stress. This effect is often overlooked. Dynamic compression occurs as the neck bends forward or extends backward, and these movements can temporarily reduce the space available for the spinal cord. In extension, the ligamentum flavum may buckle inward, further narrowing the canal and increasing pressure on neural tissue. The risk becomes greater when motion-related narrowing is severe. Studies show that a dynamic sagittal canal diameter below 11 millimeters is associated with a higher likelihood of developing myelopathy.
Cervical instability refers to excessive movement between vertebral segments during normal motion. It can be identified on flexion-extension radiographs when vertebral translation exceeds 3.5 millimeters or when angulation is greater than 11 degrees. These findings are clinically important. When the cervical spine becomes unstable, motion is no longer distributed normally across the affected segments. As a result, the spinal canal may narrow intermittently during movement, creating repeated mechanical stress on the spinal cord. The effects accumulate over time. Next to increasing canal narrowing, abnormal motion can produce recurrent microtrauma to neural tissue, which may contribute to the progression of degenerative cervical myelopathy.
Mechanical strain plays an important role in spinal cord injury and degenerative cervical myelopathy. During neck flexion, the spinal cord elongates and experiences increased axial tension. This creates stress on neural tissue. As the cord stretches, axons can become distorted and cell membranes may be disrupted. Signal transmission may also become less efficient, leading to conduction abnormalities that affect neurological function. The consequences can be lasting. When strain is severe or occurs repeatedly over time, axonal damage may become irreversible, contributing to progressive neurological decline. Cervical kyphosis refers to an abnormal forward curvature of the cervical spine. As this deformity progresses, pressure within the spinal cord can increase and place additional stress on neural tissue. The effect can be substantial. Compression from the front of the spinal cord often becomes more pronounced in a kyphotic spine. At the same time, shear forces develop as tissues are exposed to abnormal mechanical loading, which can produce localized injury to axons and disrupt normal neural function. Over time, the spinal cord undergoes persistent deformation. Next to ongoing compression, these mechanical forces can drive progressive neurological deterioration and contribute to worsening disability. Ischemia refers to an inadequate blood supply to tissue. In degenerative cervical myelopathy, spinal cord compression can reduce blood flow and limit the delivery of oxygen and nutrients that neural cells need to function. This process matters early. The location of compression influences which vascular territories are affected. When pressure occurs anteriorly, blood flow through the anterior sulcal artery may decrease, while posterior compression can reduce perfusion of the spinal cord gray matter, creating a setting where neural tissue becomes vulnerable to injury. Oligodendrocytes are especially sensitive to reduced blood supply. Because these cells maintain myelin around axons, ischemic injury can lead to early myelin damage and impaired signal transmission, which contributes to neurological dysfunction over time.
Excitotoxicity is a process in which excessive stimulation of neurons leads to cellular injury. In degenerative cervical myelopathy, ischemia can increase extracellular glutamate levels, exposing neural tissue to abnormal chemical stress. The consequences can be significant, as glutamate function and damage important structural components of the cell. Oxidative stress develops and cell membranes become injured. Next to these changes, programmed cell death, or apoptosis, may occur. Over time, these cellular processes contribute to progressive neurological decline and worsening spinal cord dysfunction.
Apoptosis is a form of programmed cell death that plays an important role in secondary spinal cord injury. In degenerative cervical myelopathy, this process continues long after the initial mechanical compression and contributes to ongoing tissue damage. The effects accumulate over time. Oligodendrocytes are specialized cells that produce and maintain myelin, the insulating layer that supports efficient nerve conduction. When these cells undergo apoptosis, demyelination develops and neural signals become less effective. This change is often progressive. Chronic ischemia and persistent mechanical stress can drive this process. Next to ongoing myelin loss, axons gradually degenerate, which may result in permanent neurological deficits and loss of function. Some damage cannot be reversed. In conclusion, degenerative cervical myelopathy is more than a simple compression disorder. It is a complex neurodegenerative process in which chronic spinal cord compression, abnormal mechanical forces, reduced blood supply, and cellular injury interact over time to produce progressive neurological dysfunction. Several mechanisms work together. These changes begin at the tissue level, but eventually affect neural pathways and functional performance. As damage accumulates, the spinal cord becomes less able to recover, particularly when ischemia and programmed cell death contribute to ongoing degeneration. Early recognition is essential. Identifying risk factors and clinical signs before significant progression can help prevent permanent neurological injury and improve patient outcomes. For more high-yield neuroscience education and practical clinical insights, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Like, comment, share, and subscribe. Thanks for watching, and stay tuned for more educational content.